Thank you and good morning. I've recently done a review with Dr. Gleave looking at the role of surgery in men with high-risk prostate cancer, and also had a look at the results here from this centre regarding their outcomes of surgery on men with high-risk prostate cancer. We're sort of going to combine the two today in the round. I'd like to begin with a case study, and I just want you to think in your heads what you would offer this gentleman. He's 55, he's a healthy accountant, he has one of these health checks where they tack a PSA onto the end of his routine bloods, which is another issue which we won't go into today. He does have a nodule in his prostate, and he has a biopsy, and where the nodule is, the cause come back as positive, and it's 4+3. I want to think, is this the sort of man you would offer a surgery to? Is it something that's high on your list of priorities? But more importantly, what options would you discuss with him? What are his treatment options, and which path would you allow him to go down, and which paths would you definitely not allow him to go down? So there's two worrying trends in the management of high-risk prostate cancer, and these are there is a decrease in the proportion of men that are undergoing surgery for their high-risk prostate cancer, and there are several reasons for this. And secondly, and most worryingly really, is that a high proportion of men, such as that man we just showed in the first case, are not getting any treatment at all for local aggressive treatment. We're really just looking at palliating these men, and I think that's entirely inappropriate. So looking at some studies that are around, this is a study looking at data from the SEER database, and really it looks at those men that have had radiation over just within a 4-year period from 95 to 98. You can see that the amount of radiation went from 40% up to 60%, while at the same time those receiving surgery went from 20% down to 10%. And as I was talking about, what's most worrying about this graph really is the number of men who are not getting any local treatment at all and are just being placed on androgen deprivation or watchful waiting. Now there is a lot of factors that go into that. Obviously that may be related to age or comorbidities, but in fact that's not been stratified for this, and this is just all comers. So a third of men, and they had to at least be less than 70 for a lot of the studies we're going to talk about, are not getting any treatment at all. If you look at the CAPTCHA database, which is gathered by the guys at UCSF, that first man that I showed you has a CAPRA score of 8. Now, a CAPRA score is another way of determining how high risk is the prostate cancer, and 8 to 10 is very high risk. That man falls into the very high risk category. And what you can see is that for a man of that, this is of community-based urologists in America, only 12% would get an operation. Now that's not necessarily what was discussed, but that's what actually happens in the final, in the final wash-up. More worryingly, over 50% of men with this highest risk category are not getting any surgery at all. The thing that's worrying about that is that there is no evidence to support not operating on these men just because of the risk of their prostate cancer. So this is a second risk. I know you probably think the first case was a little bit highly selected and probably not what we'd normally see. It's very rare to see such a young man with aggressive disease. We do see it, but it may not be what we'd see on the average. But how about this man? I think this man is exactly what we would see in clinic. And this is a 65-year-old man. He has got a high PSA. He's had his first check, or it's jumped up from one he had 4 or 5 years ago. He has got a few comorbidities, but none that would necessarily preclude him from surgery. He has got a little bit of irregularity in the prostate, a suspicion of it's T3 disease, and the cause on that side all come back as positive. It's 4+5 this time, so we're not trying to gild the lily with regards to pushing him up. This man has CAPRA score 10 out of 10, and in fact this is the kind of guy I think that community-based urologists in America are shying away from operating on. And as I said earlier, there is no evidence to support not operating on this man. So the objectives of this talk are to discuss the literature regarding the role of surgery in men with high-risk prostate cancer and to report our experience on this cohort of men. So high-risk prostate cancer has been given a definition of sorts, and that is that it's significant likelihood of progressive to symptomatic disease or death from prostate cancer. D'Amico was the first to put some criteria on this, and he came up with the Gleason score of 8 or more. Initially it was T2C, but distinguishing T2C from other T2s can be difficult, so a more practical guide is CT3 disease and a PSA of 20 or more. Now, why are people not getting surgery? And I think it stems to what's in the guidelines and what have the radiation oncologists been doing a good job of. And that is the treatment guidelines say, and they don't give an order by number, but they certainly steer people away from surgery of those that fall into high-risk prostate cancer. They recommend external beam radiation, and really the gold standard today is IMRT, plus 2 to 3 years of ADT. An alternative is external beam with seeds with a shorter course of androgen deprivation. And then they've got thirdly, and really with lots of caveats, and that is that you can perform surgery with an extended pelvic lymph node dissection, but really in select patients only, and those that don't have any fixation. But it's really the select patients of which they don't really go on to clarify. But there are advantages of surgery in these patients. It's immediate and excellent local control. You get accurate staging, which can guide future therapies or in fact avoid androgen deprivation in many men. It removes benign sources of PSA. You know what you're treating with when you've got this man sitting in front of you after an operation. It has a cure rate of 50% in high-risk disease. Now, a lot of people see that as a glass half empty. It's the epidemiologists who are saying that we shouldn't be operating on these men. We're leaving them wet for no benefit. But I see it as a glass half full. It's a pretty good hit rate when you consider a lot of other salvage surgeries or surgeries that are attempted with a cure. 50% is a very good hit rate. But it's not just about the cure rate with regards to the biochemical progression-free survival. That's what it's saying is 50% will have a PSA recurrence. But in fact, if you look at other markers, you've got 90% local recurrence-free, you've got 89% systemic progression-free, importantly, you've got a 95% cancer-specific survival, 80% overall, at 10 years. Looking again at the capture database and looking at outcomes by Capra score, you can see that with regards to PSA recurrence, those that fall into the highest risk group, which is the 7 to 10, so this is where our man, those first two cases would have fallen into, they do have the worst PSA outcome. And at about 5 years, the PSA recurrence rate, or those that have avoided any PSA recurrence, is 25%. And that's important because we're going to compare our results to that number down the track. So the question is, well, what is the best treatment? I can't bang on here about surgery all day if it's clearly not the best option for patients. But the point is that there is no randomised trial that compares, well, there's no large randomised trial that compares radiation and surgery. This question has been raised by the Institute of Medicine as one of the top questions that needs to be clarified by comparative research. But there are a lot of retrospective analyses that compare the two treatments. Of course, they must be taken with a grain of salt considering their inherent biases. The most important thing really to come out of all this is that any treatment, whether it be radiation or surgery, is far better than not treating these men. I think there'd be very few men that would be so unwell that would not be suitable for any palliative treatment to the prostate, whether, I guess not really, palliative's not right word, but some sort of aggressive local control which will give them improved outcome, whether it be symptomatic or in fact survival. So the first place to look at it is, so is it better than observation? There's plenty of studies that suggest it is, and we've got level 1 evidence of prospective trials that tell us that surgery is better than doing nothing. In fact, radiation is better than doing nothing. We've got results from the SEER database, and looking at the 10-year cancer-specific mortality, for those that had radical prostatectomy, it's 5.2%, and those that received no initial treatment, it's 12.8%, or were placed initially on androgen deprivation. All-cause mortality, 25% for those that had surgery, 42.8% for those that didn't, and that's obviously more than the 7.5% difference between the cancer-specific mortality. So surgery offers other benefits, and they may be related to the side effects of not having surgery with prolonged androgen deprivation, where men would avoid some of that, at least if they had surgery up front. We also have level 1 evidence from the Scandinavian Prostate Cancer Group with their randomised trial, and we know that this is the big trial that we point to when we're talking about the benefits of surgery. But looking at but this is really all comers of those people that had surgery, but looking specifically at a high-risk subgroup analysis, while I don't have, for looking at the trial, I don't have the information in regards to what were the absolute differences, but when you compare those that had Gleason 8 to 10 with those that had low-risk prostate cancer, so what was the difference as you compared within the treatment groups? Those that went on to have radical prostatectomy, their increased risk of dying from prostate cancer increased by 5-fold, whereas if you did not have treatment, it increased 6.9-fold. So you had a worse outcome for not having surgery. And with regards to distant metastasis, the effect was even better, and that's regarding those around 10 for radical prostatectomy. That's the increase from low risk, but it was 18.8 if you had no treatment at all. So as you can see, you do a lot worse if you haven't had any treatment. We also have the results of the PIVOT study. Now, while the PIVOT study does have its criticisms regarding its the number of patients that enrolled, those that were invited. It does show that those just looking at the high risk group, we can look at just high risk in this case, the cancer-specific mortality was 9.1% for those that had surgery, 17.5% for those that didn't. And in fact, the pivot study does come out and say that the greatest, and this is something that's consistently seen, those with the highest risk have the most to gain. So in summary, when you look at all these and put them together in meta-analyses, the absolute risk reduction for surgery over observation is in the percentage of about 7 to 11%, with a number needed to treat of 13. And that number needed to treat of 13 is a consistent number that comes out in these sorts of studies when trying to save lives due to prostate cancer. But it's not just the raw numbers. We've had statisticians such as the Vickers at MSK who have used statistical analysis to look at what is the decreased risk of death associated with radical prostatectomy. And if you're a 65-year-old man with high-risk disease, the absolute 10-year risk reduction is in the order of about 17%. So now you're getting down to sort of 1 in 6, 1 in 7 needed to treat. And some would say, well, if you're looking for a reason not to operate on someone, well, what are the reasons? And I can see that morbidities or age are very good reasons not to operate on someone. High PSA is not a good reason. This study out of the Mayo Clinic showed that those men with extremely high PSAs, you're looking at those with 50 to 99, the PSA recurrence rate at 10 year, or the PSA survival is 40% for those up to 100, and metastasis and cancer-specific survivals are impressive at 83 and 90%, and even when you go over 100, you're still looking at some very impressive survivals for those sorts of men that would traditionally you'd think, well, these are the sorts of men that are not going to benefit from surgery. But radiation also has some very good results, and this is one of the key differences and I think explains why there is the level 1 evidence, or is the fact that they've got the level 1 evidence explains why they are the top 2 choices and recommendations by the standard guidelines. And it is that external beam radiation treatment plus neoadjuvant and adjuvant ADT is superior to either radiation alone or hormone treatment alone. So you need to combine the two. Importantly, they need to be combined for a prolonged period of time with regards to the androgen deprivation. So Boller's most impressive study with regards to the proof of principle of androgen deprivation use showed that if you had external beam radiation at 10 years, the disease-specific mortality was 30%, but this could be reduced down to 10% if you gave a prolonged course of androgen deprivation. The androgen deprivation has to be at least 2 years, and I think this is, as I've mentioned earlier, the level 1 evidence to support the guidelines. Well, as I said, there's no large trial that's compared radiation and radical prostatectomy, but there have been lots of retrospective analyses. And the sum of these analyses is that there are several that favour radical prostatectomy, there's a few that support radiation treatment, and there's some that found no difference between the treatments at all, including the one small randomised trial. So just looking at the large databases that we have, obviously the largest is the SEER database, looked at almost 70,000 men who'd had localized prostate cancer treated with surgery or radiation over a 14-year period. And they used propensity score matching to try and reduce the biases between the groups. Because this is always one of the biggest problems with any retrospective analysis, is that men that go to radiation, it's been shown, do tend to have worse comorbidities, and is often the reason that they end up with radiation rather than surgery. So I guess that from a perspective of from surgeons is we are cherry picking the good patients and then trying to compare our data to the radiation doctors. But they've done everything they can to try and match these inherent biases. And in the high-risk subgroup of the SEER database of those that had prostate cancer, the 10-year cancer-specific mortality was 6.8% for radical prostatectomy and 11.5% for radiation treatment. And they then did multivariate analysis, taking into account all the different variables that they thought might explain these differences, such as comorbidities and age. And in fact, radical prostatectomy still came out as an independent predictor of better survival. The other large database is the CAPTURE registry, and it always comes with a caveat that it's just a community-based urologist and not necessarily representative of any one large group. But it does have a lot of men. It's got 7,500 men that have been treated for prostate cancer, and 10% of those have high-risk disease. And what they did was spend a lot of time trying to adjust for all the risks of the different groups, and compared to radical prostatectomy, your increased risk of dying from prostate cancer was 2.2 for radiation treatment and 3.2 for androgen deprivation. And they said there were similar results for overall survival as well. So when you look at this in a graph format, you can see radical prostatectomy is on the bottom line. And when you get out to 10 years, the cancer-specific mortality is around 6% for radical prostatectomy. So as we said, this is cancer-specific. So that 95% survival or 5 to 6% death is sort of a fairly consistent figure across the studies. And here we've got radiation with a death mortality of around 11 to 12%. And specifically looking at those men that I gave the cases for earlier, as you can see, so the first man had a Capra score of 8. So he's got a 20% 10-year cancer-specific mortality, 20% if he were to have surgery, 27 for radiation, and clearly androgen deprivation in this man is just not a suitable treatment option. And as you get up to the second case, which may be considered more realistic, Gleason 4+5, high PSA, 37%, so he's got a one-third chance of dying from prostate cancer in 10 years. It's almost 50% with radiation, and obviously doing nothing at all is not an option. So other people that have done retrospective analyses, Zalewski, 409 men, compared them, did competing risk regression analysis, and found that in the radical prostatectomy group, there is a reduced risk of metastasis, decreased risk by almost 2/3, and a decreased cancer-specific mortality again by almost 2/3 in those that had radical prostatectomy. We have other large studies, Tawari, and we've got the Albertson data, and particularly looking at the Albertson, those in the high-risk group at 10 years, radical prostatectomy, cancer-specific mortality 10% versus 20% in observation. But it's not all beer and skittles for the surgeons, and there are studies that have come out suggesting that radiation is superior. And I think this is actually a very important graph because it points to a few things that we can tease out as to what this graph is really telling us. Apart from the fact that they love pretty colours, the radiation doctors, you can see that this light blue here is those that receive external beam, seeds, and androgen deprivation. So this is really what I would consider the gold standard, whether it be, not necessarily with the brachytherapy, but certainly you'd need to have androgen deprivation. You can see that when you throw in the androgen deprivation, you end up around here. Compared to, say, external beam and seeds, you've got this large purple ring, but you can see there's probably just roughly looking at 20 or 30% improvement just by adding androgens. Looking at the surgery, you've got around 60% at 5 years. Biochemical progression-free, progression-free survival. And overall, though, as the surgery gets out, it tends to get worse. But I think this is important because you've got to remember this is surgery as monotherapy, and really in high-risk patients, I think the paradigm needs to change. Surgery as monotherapy is no longer the gold standard. But we'll come back to this because I just want to look at the differences that we get between the different treatment groups. There has been one prospective randomized trial comparing radiation and radical prostatectomy. It was done in Japan. It was a multi-center study. It's been criticized for a couple of facts, and we'll come to that in a second. But there's only 95 men. Half went to radiation, half went to surgery. It's got a good follow-up of 8.5 years. And they found no difference at all between the key factors that you would use to compare surgery and radiation. One of the major criticisms is obviously the number of people in it. But the second one is that, in fact, that the radiation given to these men would be considered substandard by today's, by today's standards. And this is always one of the problems with radiation. It's very difficult to compare because they change it every 5 to 10 years, and it is getting better all the time. And by the time a trial comes out, it's almost like that radiation treatment is no longer considered the gold standard, despite the evidence supporting it. So in summary, there's no large randomised trial. There's no level 1 evidence comparing the two. There are a lot of stringent, well, they've done their best to compare them, and they do suggest that radical prostatectomy is superior. But I think most importantly, and this is really the key thing, there really is nothing that suggests that surgery, is inferior to radiation. And there's no reason that these men should not be getting offered surgery, at least in the discussion, with their high-risk prostate cancer. So I mentioned, I don't think surgery in these high-risk patients is something that's considered, should be considered in isolation. It's part of combined modality treatment. And the other things that you can throw in to treat this man is going to be adjuvant radiation and possibly adjuvant androgen deprivation treatment. And we've got modern surgical techniques as well to optimise the outcomes for men with high-risk prostate cancer. So we've talked about well, we will talk about the technique. It's all about a wide local excision of the neurovascular bundles, remembering this is a cancer operation. It's an en-bloc removal of both layers of dentin villus fascia, precise dissection of the apex, where you get a lot of positive margins, wide resection of the bladder neck, another place for positive margins. There's no place here for bladder neck sparing procedures, and extended pelvic lymph node dissections advocated by some. Pre-operative MRI can help decide those men that would be inappropriate for surgery. If there's obviously a lot of extracapular extension that's going to be close to or invading into the rectum or the region, then you could sort of make the decision that this man would be more suitable for radiation. And the good news is for Dr. Goldenberg is that the robotic-assisted lap prostate has comparable results to open prostatectomy, even in these high-risk men. But I must say that some surgeons, even the robotic surgeons and Dr. Goldenberg, having worked in the clinic, says that even in those with very high risk, you may choose to do it open because they do like to be able to feel the cancer, and it does help. You know, while you get the increased vision, that's really one of the things. Is no tactile feedback in the robot. It can be tough to tell what is cancer and what's not when you're going around the bladder neck. So just looking at the difference, so really there's a lot of time is spent on nerve spare and whether you're going intrafascical or interfascical, but with a wide local excision you just take the whole lot, get down onto the rectum, making sure that there's no chance that you're going to leave anything behind in the neurovascular bundles, because that's where the most likely site of extraprostatic extension will be. So adjuvant radiation treatment is another prong in our armament with treating these men. It is indicated in those with extensive T3 plus disease or a significant positive margin. And what you can do is you can take someone from around a 50% biochemical recurrence-free survival and increase it up to about 75%. So you can sort of halve the number of people that will have a recurrence, suitably chosen for adjuvant radiation treatment. But as has come out recently in a study, whether the biochemical progression-free survival is an indication of overall survival or important outcomes is sort of controversial, but certainly it's one of the best markers we have at the moment considering its infancy. You don't need to offer adjuvant radiation to every man that has a positive margin. A lot of these can be watched. In fact, we do watch them in the clinic here. The most important question is that those trials that showed that you can halve the recurrence were really comparing immediate adjuvant treatment for those that are at high risk to those that were treated with observation with possible delayed radiation treatment. But in fact, the question now is what's best. Obviously, radiation decreases your biochemical recurrence rate, but does it need to be given immediately after surgery within 4 months, or in fact can you do early salvage, so watch the PSA till it gets to 0.2 or 0.4 and then instigate, and that may be 6, 12, 18 months down the track, or in fact longer in some cases. Do you benefit from getting it straight away, or will you still get the same effect even if you wait? And I think this is the most important question. It's going to be answered with radicals and raves. As I left Australia, raves were sort of really beginning to mature. Now, there's the role of neoadjuvant chemo and androgen deprivation as being controversial. It certainly does benefit the neoadjuvant hormones with regards to pathological downstaging and decreases the surgical positive margin rates. But in fact, despite all the hype regarding these apparent downstaging effects, it doesn't have an overall effect on biochemical progression-free survival, cancer-specific or overall survival in the early studies that were performed. Adjuvant androgen deprivation probably does have a role, and this is not surprising when you consider the success that the radiation doctors get when they add androgen deprivation to their radiation regimes. It can't just be because they've done comparisons of 3 years versus 6 months adjuvant deprivation, and what they've found is that the 3 years does a lot better than 6 months. Now, one of the arguments for adding hormone treatment to those receiving external beam radiation treatment is that it chemosensitizes the cells to radiation, therefore they respond better. But you could make a pretty strong argument that that effect should be covered by the 6 months of neoadjuvant and adjuvant hormones. Therefore, what is the benefit of the extra 2.5 years? And I think this has to be a direct benefit on treating micrometastases or cancer cells that have already made their way out of the prostate. And the Messing trial really shows that this can be supported in surgery. So you've got those men that had node-positive disease, and there was a significant improvement in all aspects of survival in those that had prolonged adjuvant deprivation compared to those that had delayed treatment. We also have a preliminary report from the SWOG trial And those that had extensive extra prostatic extension or high Gleason grade went on to receive 2 years of androgen deprivation, and they found that there was a reduced rate of disease recurrence and cancer-specific death. And at 5 years, the biochemical progression-free survival in those that had surgery plus androgens now goes up to 92.5%. Now, these are the most impressive results from a high-risk prostate cancer surgical series. And as you can see, you're now taking what would normally be the standard of around 60% at 5 years up to 92%. So you get that 20 or 30% improvement in 5 year survival from the addition of hormones. Obviously, there's a lot of caveats regarding the use of hormones and the risks that go along with it. So as I was just saying then, so instead of being around this 60% at 5 years, you're bringing it up to about 90%, and now you can see that you are about on par with the best that the radiation oncologists have to offer. Well, what's the role of neoadjuvant chemotherapy? Well, at the moment, neoadjuvant chemotherapy, while it's also had the effects of downstaging and reducing positive margins, it hasn't had an overall effect on biochemical progression-free survival. As Dr. Gleave points out, how many men who have metastatic cancer and the first thing you do is give them chemotherapy? It doesn't work. There is no sound biopathological basis for treating unstressed prostate cancer cells with chemotherapy. What you need to do is you need to stress them with a low androgen state, and this is where chemotherapy has its effect. So that raises the role of the CELGB trial, which looks at neoadjuvant chemo and hormonal therapy. So stress the cells in 2 ways, and this may have a greater effect on metastatic disease. This is a phase 3 trial, and it's still running. So I think when we're looking at surgery, it really just becomes a discussion. I'm not here going to say that these men should be getting surgery, but I think it should be part of the discussion. When radiation oncologists are seeing patients, or we're seeing patients with high-risk disease, it's a discussion of this is surgery or radiation treatment are your 2 options. There's nothing to suggest that one is any better than the other. The advantages of surgery that we can discuss with our patients are this. It gives you a definite histopathological diagnosis, gives you excellent local control, gives you early detection of treatment failures when the PSA level begins to rise, and surgery is part of combined modality treatment. It's not a monotherapy. It does have a high cure rate, and a lot of men can avoid androgen deprivation. It does have reduced costs, and I guess there's a question, is there a role considering is there a role for cytoreductive prostatectomy, considering those men with metastatic disease in their lymph nodes that have surgery do better than those that don't have surgery? And one of the advantages is that you do get an accurate histopathological stage that you don't get with radiation treatment. From the multiple of databases that are out there, around 1/3 of men will be incorrectly staged preoperatively. That's around 1/3 will be given a Gleason score of 8 that will be downstaged, or approximately up to 1/3 of patients that will be given CT3 disease, who in fact will have organ-confined disease at their final specimen. So most importantly, many men will be cured and not have to go on and get the adjuvant treatments that a man with high-risk disease would need to get the maximal benefit. Radical prostatectomy offers excellent local control. It's got biological and psychological benefits of debulking the tumour, and I still enjoy Dr. Goldenberg's quip to patients when they're going home the next day that they're going home healthier than they came in. It can remove the prostate as a future source of metastatic cells. It has a local recurrence rate of only 13%, and that adjuvant or early salvage treatment cures another 50% of men that will have a PSA recurrence. And so this represents a 3-fold reduction in death from prostate cancer just with surgery. This is one of the key differences as well with surgery, is that when you remove the prostate, you should remove all the PSA. There's a difference in the definitions of failure after surgery and radiation treatment. For surgery, we consider a PSA rise from 0 up to 0.2 nanograms per mil as a PSA recurrence. Due to the inherent differences and the fact there's still a prostate that becomes inflamed and has some weird phenomena going on post-radiation, such as the bounce phenomena, they've given their definition of failure is a rise of 2 nanograms per mil from nadir. This is necessary so that you don't attribute too many people with false positives. But also, there's a period there where you're missing an opportunity to cure men Because while a lot of them may go, have a bounce that goes up 1 nanogram, they may nadir at 1, goes up to 2, 2.2, but then comes down again. That's great, you've avoided treatment. But every now and then, that man's going to go from 1, 2.2, 2.6, 2.9, 3.3. He's failed, and in that period, you really had to wait and see, and you've missed an opportunity to treat early, which is very important in prostate cancer. Because with surgery, we've got data for this sort of delay. And looking at salvage radiation treatment was most effective in patients with a low PSA. The 10-year biochemical progression-free survival was 50% for those with a PSA less than 0.5. However, if you waited until the PSA got to 1.5, the cure rate now was only down to 15%. So I guess by the time you're waiting for that extra 1.8 nanogram per mil rise, there's a lot of time that you've missed that these cancers could have metastasized. I think it's important, as I said earlier, really the paradigm for treatment for these men is that you'll be getting combined modality treatment. Expect to get adjuvant radiation, expect to get adjuvant androgen deprivation. But in fact, some men are just lucky enough not to have to go through that. I think that's a way. You've got to set their expectations, and this may be a way that we can put surgery in context. So it does have a high cure rate, as I've mentioned. Many men can avoid androgen deprivation. We shouldn't underestimate the morbidity associated with androgen deprivation, as many men enjoy their holidays, certainly in intermittent androgen suppression. While this isn't something we discuss with our patients, there's something to be said for the reduced costs of surgery over radiation treatment. There's a couple of studies that have been put out regarding the cost. We have that from Massachusetts General Hospital. They tried to take everything into account in looking at the actual cost of the procedure and getting to the procedure. With radical prostatectomy, it was $13,500. For those that had IMRT, it's $23,800. And just to put it in context for the next study, 3D conformal external beam is about $15,500 to $16,000. So it's about $2,500 more expensive. Looking at the SEER database and the cost to Medicare, this is Americans obviously, not necessarily relevant to us. Surgery, this is in the first 12 months, and this includes any costs attributed to complications or extra treatments in the first 12 months. And we're looking at surgery, including any adjuvant treatment, it was $15,500, and those for 3D conformal was $17,800. And when you take into account the fact that you need to add on at least another 12 to 24 months of androgen deprivation, which in Australia is about $1,500 every 3 months, that's an extra cost for those men receiving radiation treatment, whereas only 50% of those receiving surgery, I guess, potentially could receive it. And then the question is there a role for cytoreductive prostatectomy? This is controversial, it's not something we're advocating, but there is evidence that removing the prostate in men with minimally metastatic disease, they do a lot better. There's been 2 retrospective analyses of node-positive disease, and looking at the 10-year overall survival, those that had radical prostatectomy for primary debulking and then androgen deprivation had a 65% overall survival at 10 years, whereas those where surgery was aborted or not performed, the outcome is 30%. But this isn't just from retrospective analyses. Studer wrote a great editorial a few months ago and said that in fact if you look at the 10-year overall survival of different arms, not just in these retrospective analyses, the data still stacks up. So you look at the Messing trial, those that had radical prostatectomy with prolonged adjuvant androgen deprivation, 65% 10-year survival. If you look at the EORTC trial, which compared, is written down here, late versus delayed endocrine treatment in patients with node-positive disease who didn't have surgery. So if you just look at the arm that received androgen deprivation alone, this was obviously being compared to no treatment, but with androgen deprivation alone, they had a 30% overall survival. So there's something to be said for treating the prostate, even in people with minimal metastatic disease. So there's the data, but there's also the pathological or the biological basis for it. Primary cancers release metastases and growth factors, and a lot of research going now into the establishment of the metastatic niche in bones by growth factors or cytokines released from the primary cancer. And really, we know that the immune system is important in cancers. Just take cytoreductive nephrectomy in the era of immunotherapy for kidney cancer, but also prostate cancer is the first cancer to have a vaccine-tailored treatment, which is obviously trying to involve the immune system in the treatment of prostate cancer. But the bottom line is that we need a randomised trial to establish whether this is going to be any effect at all. Why wouldn't you have a radical prostatectomy? People argue the morbidity is too high, the risks outweigh the benefits, but in fact there is no increase of complications. Most men are going to be impotent after external beam and adjuvant hormone treatment anyway. Some people argue you're operating a man with a terminal disease, therefore why would you operate on him? But in fact, with modern anaesthesia and perioperative care, most men go home day one. You have the advantages of pathological downstaging. Men with high-risk disease have the most to gain. And importantly, when I was training, we were told that if someone had a 10-year life expectancy, then that was the man that was appropriate to offer a surgery to. With newer treatments coming through, such as abiraterone, MDV-3100, alpha-radin and more, in fact, we keep pushing back. We're turning this into from a terminal to a chronic disease. Now the question is, how do we compare? How do the men in this room compare? What are their rates like? 565 men were collected on a prospectively collected database and underwent radical prostatectomy between 1991 and 2012. High-risk prostate cancer using the standard definitions, and just looking at around half the men had neoadjuvant therapy, a very small proportion had adjuvant treatment, and RP or radical prostatectomy monotherapy was performed in 230 men, so 40%. We define PSA recurrence as 0.2 or any sort of salvage treatment. These are the patient characteristics, as shown them as with all prostate cancer trials. Median age is 63, and the PSA increases as the number of risk factors, so the PSA, Gleason score, T3 disease increases. And this is our overall result from the surgeons here. We have a 60% 5-year survival and a 50% 10-year survival. When you categorise by risk factor, you've got 66% 5-year survival if they only have one risk factor. It decreases significantly if they have two. And if you have 3 risk factors, in fact no man has made it past 2.8 years before having a PSA recurrence. That's 20 men in this group. Neoadjuvant treatment didn't make a difference to overall outcome. In this case, considering the rate was very low, adjuvant treatment didn't make any difference. And those men that had radical prostatectomy as monotherapy didn't do any worse. It's got to remember, these are men that had monotherapy, considering that we're a tertiary centre and have a lot of, 50% of people had neoadjuvant treatment. Men that went on to monotherapy are probably a highly select group that had the least risk factors. So it's important to note that they didn't do worse. But I think this is one of the key slides here, and this is men that have a CAPRA score of 7 to 10. So you can see that they have a 48% 5-year biochemical progression-free survival. And that's compared to, in the CAPTCHA database, at the same point, it's 25%. So men here do about twice as well. Now whether that's, they talk about the importance of high volume surgeons, high volume tertiary centres, or whether it's even related to the fact that we have a lot of men that have had neoadjuvant treatments or that haven't been borne out in trials. But I think what it does show is that a lot of men, even in the very highest risk category, will do very well from surgery as their primary treatment option. We also had a look at our CT3 disease. So these are men that, in that first slide that I showed you, how only 10% were getting surgery. You can see 50% of men will still have a 5-year biochemical progression-free survival. And when we looked at multivariate analysis of our results, the only independent predictors were biopsy Gleason score and having 2 or 3 risk factors. So in conclusion, our results here in Vancouver, 5-year biochemical progression-free survival, 60%, at 10 years it's 50%, and the biopsy score and having 3 risk factors are the only independent predictors of a poor PSA outcome. So I think it's important to realise there is no evidence to support the fact that radiation is better than surgery, and it should be part of the discussion. And while it's almost certainly never going to happen, a randomised trial would be the only way to decide this. I think that's it. Thank you very much.